together leading minds in anesthesia and perioperative cardiac care. From goal-directed therapy to heart failure and optimization of high-risk patients, we have a power-packed session ahead. May I take this opportunity to invite our distinguished chairpersons of this session, Dr. Utkala Hegde, Professor, MVJ Medical College, Bangalore, Dr. Manjunath R. Kamath, Professor, Cardiac Anesthesiologist, KS Hegde Medical Academy. We welcome you to the stage, sir.
Our first talk sets the tone for the session with the insights into goal-directed hemodynamic therapy, a clinical compass for intraoperative management. We are pleased to invite Dr. Pradeep A. Dongre, Senior Consultant at Vasavi Hospital, Mangaluru.
Good morning, everyone. So I bring warm greetings from Vasavi Hospitals, Bangalore, and I'm grateful and honored by this invitation from Mangaluru. So we are good today. I'm here to talk about updates in goal-directed hemodynamic therapy, the hemodynamic GPS. So this was a topic allotted to me. So going back a little bit into the history of goal-directed therapy, hemodynamic therapy as such, it began long ago in the 1970s and 80s. 70s started with the use of pulmonary artery catheters, and that was when it was invented. And 1980, pulmonary artery catheters came into vogue, and along with them, with that, there were a lot of studies done in the intensive care units and critical care units where, Bland et al. And Schumacher et al., they were the pioneers in goal-directed therapy. And Bland et al., he conducted an observational study, a descriptive study, and he found that most of the patients who survived with all these diseases on the right side, AKI, sepsis, those who had undergone emergency surgery, multiple trauma, etc., all of them had supranormal hemodynamic levels, whether it was in terms of stroke volume or cardiac output, cardiac index or whatever. So this was just a descriptive study that was first published in 1980s. And then in 1988, Schumacher, who was also an author in this particular trial, went on to conduct another trial. He divided all the patients coming into his CCU, which were post-surgical. He divided them into 3 groups. And they had all these factors, one of these 7 or 8 factors that were there. And he divided them into 3 groups, and he created a protocol where in one group, he maintained supranormal cardiac output levels and cardiac index levels and looked for the outcome. He found that the outcome of these patients was way, way better. So this is how our goal-directed therapy began. So they even hypothesized that this is very, very good, mainly in high-risk patients alone, either high-risk surgery or those who had comorbidities which made the surgery or anesthesia high risk in them. Fine. So as I mentioned, they didn't advocate it in low-risk surgical patients at all. Subsequently, what happened was these goal-directed targets, and they were extrapolated to the perioperative period, and most of them started using these goals, targets, and etc. in the perioperative period, and they found that similar results. The outcomes were better in high-risk patients. So what is this goal? Actually, basic goal is maintaining cellular oxygenation. That is what we are actually looking at. If the cellular oxygenation is maintained, then the outcome of the patients will be better. That is what we have, that is what is the hypothesis. Since we actually cannot measure the cellular oxygenation as such, we rely on surrogate markers. We rely on the assumption that macrocirculation, improvement in the macrocirculation actually will improve the microcirculation of each organ and hence maintain the tissue oxygenation. So this is the background. So what are the updates? What have we actually found by repeated research over time is, some patients do have what is called as hemodynamic coherence, or the macrocirculation improvement improves their microcirculation. Okay? Whereas there are some patients, especially those patients with sepsis, those patients with inflammation, these patients, there may be hemodynamic incoherence, or macrocirculation increase does not increase the microcirculation levels. So why does this hemodynamic incoherence occur? There are many things. There can be a blockage of the blood flow as such. There can be difference in the blood flow between different sites in the particular organ itself, or difference to different organs as such. Hemodilution can occur because of various reasons intraoperatively, and this hemodilution can reduce the oxygen carrying capacity of the blood. There can be low arterial venous gradient or capillary stasis can occur, which can lead to, again, incoherence. And there can be edema, which can increase the distance of travel of this oxygen. Okay? The basic thing is tissues have to get oxygen. So we have understood these things of late. This is the recent things that, based on the concept of how, goal-directed therapy may help. Now, recently we have two consensus statements based on all these understandings. Okay? One is a consensus statement on goal-directed fluid therapy. The second one is a consensus statement of goal-directed hemodynamic therapy as a whole. So we'll see the difference between these two slightly later on. So I'm going to treat both of them in collusion, because one cannot go without the other. Fine? So now, what are the newer updates in monitoring targets? So whatever we used to, whenever we studied about goal-directed therapy, we always talked about mean arterial pressure. But we have to remember that most of the targets are about the cardiac output or cardiac output markers rather than the mean arterial pressure alone. And again, stroke volume is now considered as the best marker for targeting in patients who are at high risk. And then microcirculation monitors are coming into vogue. They are not yet available. Probably they would improve the level of understanding of microcirculation later on. So if you look at the physiology, there are some updates even in the physiology. The whole concept of hemodynamics and improvement of stroke volume, improving the circulation and improving the preload, afterload, all these things came with the Frank-Starling law or the Frank-Starling mechanism, wherein Frank and Starling together, they put forth the theory that if the cardiac muscle, left ventricular muscle is stretched more, it produces more stroke volume. This was the basic funda of that. And nowadays we have begun to think that there are some updates to this. There is not single curve in each patient. There may be multiple of curves at different pressures, different mechanisms may be involved in that. If the afterload increases, the pressure, the curve may change. So there are a lot of understanding, changes that can go on in the patient. So you cannot say that all patients are in the upstroke of the Frank-Starling curve and giving fluids will actually improve their stroke volume. So what we look at nowadays is the stroke work rather than the stroke volume. Other than that, there have been a lot of updates with regard to the fluid responsiveness of patients. So when the older funda was that whenever the patient has a undergoes anesthesia or whatever, there'll be vasodilatation, you need to give a lot of fluids. So nowadays we are seeing patients, we are looking at patients to see if actually giving fluids increases the stroke volume as such. That is what we are actually looking at. So there are two concepts that have come up. One is the stressed volume and the unstressed volume. This is with relation to the venous system. So whenever the venous system is distended, or there is enough amount of fluids within the venous system, this produces a pressure, and there is a mean systemic filling pressure that develops and increases the preload or the venous return to the heart, increasing the cardiac output or the stroke volume. So again, many of the studies and researchers have seen that, and the unstressed volume can be converted to the stress volume by using alpha agonists. So there is only one thing that you have to be careful of when actually this happens, that using an alpha agonist in the beginning, if there is beginning of surgery as such or in the perioperative period, can actually convert the unstressed volume to the stress volume, which can actually mask the requirement of fluids. So the actual the patient may be fluid responsive, but you're masking it by giving a alpha agonist. So again, the newer concept says that intravascular hypervolemia is different from fluid overload. We cannot say that all patients who are fluid overloaded or have edema actually have a good amount of intravascular volume, and vice versa too. Okay. So, and a lot of research has been done on this in the perioperative period and in the critical care units, and they found that only 50 to 60% of the patients are fluid responsive. That means you give them a fluid challenge, and they respond to that by an increase in the stroke volume. Okay, so this is what we actually look at. So how do you test? There are 3 ways you can look at it. 500 ml balanced salt solution gives a 15% increase. You can give this 500 ml over 10 minutes and see if there's an increase in the stroke volume by around 15%. Nowadays, nobody does this because 500 ml is quite a lot of volume, and you're unnecessarily increasing the fluid levels by giving a large amount of fluid. So they brought it down to 250 ml. Later on, they said 250 ml, if the stroke volume increases by 10% by giving 250 ml in 10 minutes, fine, the patient is fluid responsive, you can transfer fluids. So he requires fluids. Now they've gone further and said that 100 ml, give it over 1 minute. If the stroke volume increases by 5 to 6%, then you can continue with the 250 ml balanced salt solution to see the fluid response. Okay. So as I said, so what is the optimal goal? You're trying to give fluids to see what the response, whether the patient is actually requiring fluids or not. What is the optimal goal? We should remember that in 80s to 90s to 2000s, we were still using pulmonary artery catheters to measure the cardiac output and the stroke volume. And stroke volume became the optimal goal to look at the increase in the cardiac output. Okay. So now there has been a shift to minimally invasive methods. We no longer, most of the time, we don't use pulmonary artery catheters nowadays. We use minimally invasive methods, and we use non-invasive methods also. So nowadays, we are looking at stroke volume variation. We are looking at systolic pressure variation, pulse pressure variation. All these things are being looked at. But most of the studies that have been done are still they still prove that stroke volume is a better marker to look at rather than all these things, because these can vary with respiration. So this is one study where they found that this is one, this is a consensus statement where they found that there was interference with all this systolic pressure variation, pulse pressure variation, stroke volume variation, pleth variability index, all these things. There was an interference if the patient had an open chest, small tidal volume, spontaneous breathing, etc., etc. Hence, still now, esophageal Doppler and other minimally invasive cardiac output methods still remain the mainstay of measuring the stroke volume. And stroke volume still remains a better, marker or a target. So there was another study, meta-analysis of randomized controlled trials conducted, which showed that there was significant reduction in the morbidity, length of ICU stay, length of hospital stay, time to passage of feces. And there was one more important thing that they found. This was done somewhere in the 2020, and they found that all these were lost if ERAS protocol was actually followed. The benefits were lost. So probably because of preoperative fluid loading or preoperative or co-loading or whatever, the patients fared the same as any other patient if they followed the ERAS protocol compared to goal-directed therapy. So again, to reiterate, most of the findings have shown that mortality benefit is always only with high-risk patients, and there was a meta-analysis to say this. It included 32 RCTs and 2,208 patients. So risk of death is reduced only in high-risk patients. So there have been some studies which have been done comparing minimally invasive or invasive and non-invasive methods and minimally invasive methods. All have found that non-invasive and minimally invasive methods may be comparable to invasive methods when assessing the cardiac output and the cardiac index and the stroke volume. So 2025 July, there was a consensus statement published on goal-directed hemodynamic therapy. And it found that, there are protocolized approaches and assessment methods, and this would definitely improve some of the things, okay? So they said that GGHD is an umbrella term for many things, including fluids, vasopressors, and inotropes. They found that as I said, it can optimize tissue oxygenation, but you have to beware. Inflammation, infection may not help it. They found that there has to be clearly defined paths and physiological targets. These are some of the things: setting, monitor, variables, target, and intervention. All these have to be protocolized in your institution to see benefit. Then minimally invasive methods are still, they can be used. They are better than non-invasive methods. Then fluid responsiveness is again still remains the key. Vasopressors and inotropes can be used. They may improve. They are for maintaining the MAP target rather than anything else, and the cardiac index target. So dynamic variables can be used, but again, they are very unreliable. This is what I had already mentioned before. What about fluid responsiveness? So how you have to go about is optimize the blood volume, optimize the MAP targets, and optimize cardiac function. There have been small trials done on surgical situations. They found that pneumonia is reduced, AKI is reduced, mortality and length of hospital stay is reduced. And they found that it's basically for high-risk patients. Individualize the protocol, especially when it comes to non-cardiac surgery. They don't recommend it for routine non-cardiac surgery, again, elective ones, neither for emergency surgery. Low-focused inotropes are not recommended anymore. There have been, this is one study which actually, proved that. Then they have found that when it comes to cardiopulmonary bypass, definitely goal-directed therapy can reduce the incidence of AKI and can reduce the incidence of pulmonary complications and etc., postoperative complications. And currently, there is insufficient evidence to recommend GGHD in emergency abdominal surgery. And perioperative, it is recommended in patients coming with hip fractures. So in summary, basically GDHD is nothing but individualized care. You have to be individual, and you have to develop your own protocols. GGHD is just the umbrella term, and it's beneficial in high-risk surgeries. Minimally invasive monitoring is better. Target the population, timing of the intervention, type of intervention, target variable, and the target value. These are the 5 T's for goal-directed hemodynamic therapy. Thank you.
Thank you, Dr. Pradeep Dongre, for sharing your expertise with us today. Thank you.